the master, Dr. Sandeep Diwan sir. He is consulting anesthesiologist at Sancheti Hospital, Pune. He has got various publications and research works going on and even published. I would like to welcome Dr. Sandeep Diwan sir. Good evening, sir.
Yeah, good evening, Abhishek.
Yes.
So can we start?
Yes, sir.
Yes, sir.
Okay. So thank you very much again, Dr. Abhishek, who is in my department as well, and Dr. Sangamitra as well as Dr. Hetal. So we are looking into some of the.
Abhishek, I'm muting you.
So this is some of the cadaveric insights from the thoracic areas. So it has evolved over time. In the past few years, we had been doing only the thoracic paravertebral blocks, but then since then, various other blocks have been evolved. Now this is a cross section at the level of maybe T4 or T5, and this was when we were in grass and we had the opportunity to have a cross section. And what you will find here is the the entire vertebral body, the transverse process, and the costochondral junction and the costovertebral junction, and then you will find the ribs at various levels, and these ribs, they keep on emerging as you take the cross sections until you go at the level of this sternum right in the front, in the ventral part. Now encased is the spinal cord here between the lamina. This is the spinous process, and then you have you can see the epidural space with the venous plexus, which is situated on the lateral side. You can see the thoracic nerve root, and these nerve roots then they emerge through the intervertebral foramen, and this dark blue you see is basically the ventral nerve, which then goes on to form the intercostal nerve and then travels the intercostal pathway, which will be just behind the parietal pleura. So there have been levels which have been evolved over a period of time. Initially was the intercostal at around the costal angle, or maybe around 8 to 10 centimeters from the spinous process laterally on both the sides, where the intercostal nerve would be a bit more superficial than at the other levels. Then came the erector spinae, followed by the serratus, and then the various blocks in the region of the pectoralis major. So this is how it has evolved over time. So the intercostal nerve, as it emerges, it passes beneath the rib in the intercostal groove, along with the artery and the vein, and it travels, and it can give off at various levels. It can give off the posterior, the lateral, and the anterior branches, and which again forms the medial and lateral, the anterior and posterior, and the medial and lateral respectively for those particular branches. And these are the branches that we get hold of at the erector's spinal level, just at the level of the transverse process, which is again become a very important anatomical landmark. Now, this is at the level of the serratus anterior plane, where you can inject either superficial or deep, and this will be in between the pecs and the sap. So let us look into the thoracic paravertebral block, which was a block of my choice way back. I mean, almost like 15, 20 years back, we used to use only the thoracic paravertebral block. Now, this is a very good article, and if you want, this is from 2001, and this is a review article by Manoj. And the schematic diagram has been incorporated in that particular article. Now, what you see here is again the same. Through the intervertebral foramen will form the dorsal root ganglion, and then will emerge the ventral nerve, and the ventral nerve will traverse in the as an intercostal nerve. but more important, what it has been depicted here is the endothoracic fascia. Now, this endothoracic fascia is one that it lines the parietal pleura, and it forms the two compartments. Very important is the extrapleural compartment, which is the ventral compartment, and the subendothoracic compartment, which is the uh, dorsal compartment. So these two compartments have been noted earlier, and you really don't appreciate with the needle tip whether you have really transgressed the endothoracic fascia. But more important is one important area where you have to be very careful is the transverse process and the superior costotransverse ligament, which is between the transverse process and the rib, the tip of the transverse process and the rib. And the feeling of that is even not like a ligamentum flavum, which exists here, but it is something like a subtle feel of loss of resistance, and beyond which your needle tip lies in the paravertebral space. So this paravertebral space is basically a space which is lined by medially by the vertebral body, the intervertebral foramen, and part of the transverse process, the ventral part. Anterolateral, it is by the entirely by the pleura, and posteriorly, it is the costotransverse junction, or it can be the costotransverse ligaments, along with the costotransverse ligaments. So that could be the possibilities. Now, what it contains is the ventral rami, as has been described, and you can see that if this is the epidural space, or this is the dura, and this is the epidural space, this dura, it encompasses the ventral nerve, but we are not unsure until what extent it's going to go, because then it merges with the perineural area, and you can see the fat which is around the nerve, this particular nerve. So we are unsure whether the dura, it encompasses the fat as well, or only the nerve along with it, and then at what area, at what particular point the dura ends and the perineurium begins, or what is the dural perineural interface. And has mentioned that it can be around 8 centimeters from the spinal cord or from the intervertebral foramen. So that could be very long, and it could end in fact somewhere in the intercostal area. And I remember that there are a few articles which mention that if you inject in the intercostal, they have found that the patient going in total spinal, 20 ml at the intercostal area, the patient going in total spinal, probably there's the whole of the drug is being carried, migrating and diffusing into the into the intrathecal space. So that is a possibility. The second is uh, apart from this the boundaries, the superior and the inferior, the space is continuous, a column like. So probably if you are going to insert your needle into this particular space, then you can get a continuous flow of the drug from the that is from the cranial to caudal, and it may be along 3 to 4 interspaces. So that is again a possibility. Now, one thing to be remembered is that the dorsal rami, it usually exits around this, and then around this area, and then it goes more uh, dorsally and innervates the erector spinae muscles, the spinous process, the part of the periosteum of the facet joint, and even the facet joint also through the medial branches. And what all you can see, the pores or these pores. So probably these are the ones that are communicating from the dorsal to the ventral aspect, from the dorsal to the ventral aspect. So this is one of my suppositions that this could be a track or a path from where the drug can migrate from the dorsal to ventral. Now, in the past, what we used to do is we used to give a landmark guided block. And this is very important to understand that I usually have some cadaveric models. I think we should again have it in CRAP. Earlier, we used to have, and we used to do the non-ultrasound guided. Now, here we used to give the feel of the spinous process, feel of the entire ribs, and then you go around 3 to 2.5 to 3 centimeters lateral to the spinous process, insert your needle and try to hit the costotransverse junction and then just go beyond it and try to inject. So we used to ask the delegate in front whether I'm in the right path, and then the delegate used to take over the procedure, and then the delegates friend used to look at whether they are in the right path. So we used to have the 2H needle because this is the one which is more useful in the formalin based, and then you gauge your the way you do it. I'm trying to hit the costotransverse junction, and then either you go cephalad or caudal. Usually the cephalad is more preferred than going caudal. And once you are in that particular area, you can feel the loss of resistance now going more caudal. That's it. And then you attach the syringe and then you inject the colored dye. So once that is done, then you inject the colored dye and you see how it tracks in the paravertebral space. So this is how we used to do it in the past. So once the dye was injected with the needle in the paravertebral space, it used to go along the paravertebral space. Now this you are looking from the ventral side, that is the inside the thoracic cavity. You can see the vertebral bodies. These are all the vertebral bodies, and these are the ribs. These are the intercostal muscles, and the dye has taken exactly the course of the paravertebral area where the motor and sensory nerve would lie. And the more important is the sympathetic ganglia, which would lie in the paravertebral space. And you can see the dye is going into the prevertebral and probably going into the contralateral paravertebral space, which is what was a quite common occurrence in that particular area where you are going to inject. But as you go more caudal or go more cranial, the dye is to be confined in the paravertebral space. Now, if you look at this particular figure, you can see the sympathetic ganglion here. So this is in the prevertebral area, and this is the point where we used to give even the splanchnic nerve blocks at these particular areas to block the greater splanchnic and lesser splanchnic if the celiac plexus block was contraindicated. So we used to use these blocks for some of the surgical procedures. This is a bit clinical, but I don't mind using these videos here because it will give you a clue of how the paravertebral block was used by landmark technique in the past. This is a baby of Teo fistula, which I used to do in the past until 2014. This is the spinous process. I'm calculating how I have to go spinous process. It cannot be, of course, 3 centimeters. It has to be just the interspinous distance is equivalent to the distance you go lateral from the spinous process. Try to hit the costotransverse junction probably, and then the needle tip, it just skirts above the costotransverse and then inject the local anesthetic. I injected methylene blue just to indicate whether I'm in the right place. Methylene blue is given in chronic pain, so that should not be a problem. Only thing is it has to be at the right dose for the infant as well. Now, this methylene blue is seen, it has been tracking exactly in the paravertebral space. There's no spillage into the pleural cavity. And you can see the entire very close to the paravertebral space, which will block the motor and the sensory components. And this is the radical mastectomies, which we used to do with the paravertebral blocks plus the interscalene block. Now, the interscalene block was done to block the pectoralis, the nociceptors from the pectoralis major and minor. Now, needles which were introduced by landmark techniques. You can see that how the needles were introduced. Now, these needles, you can see they are almost at right angle to the transverse process. This was a very important contact point. That is called as the osseous contact. And just beyond this, around 1 centimeters, it would be the length of the needle from the transverse process. Now we used to inject contrast and see the spread under CT scan, and you can see that it nicely delineates the paravertebral space, and there's no spillage into the intervertebral foramen, no spillage into the epidural space, and it is going more lateral and going more caudal. We usually used to have all the sections like the sagittal, axial, and the coronal sections to have a look at the uh, extent of the dye spread. And based on that, then we used to give these neurolytic blocks. So I used to use 100% alcohol for patients with chronic pain. Catheters could be introduced again with the same landmark techniques, and you can say the catheter is rightly placed. Now, why the catheter would be rightly placed is because the catheter is at the posterior vertebral line. Now, this is the anterior vertebral line, this is the posterior vertebral line. The catheter cannot go beyond this. It can, but it should not. And it should lie somewhere at this point. Now, this is the paravertebral space. Anterolateral is the pleura, posterior would be the costotransverse junctions, and medially would be the intervertebral foramen, the vertebral body, and the facet joint. Now, whatever contrast you inject, it would be confined in this space. It all depends upon the speed of injection, the volume of injection, how much would go into the epidural space as well. Now, why I say that it has to be at this particular line, this is because I had one patient where this catheter had migrated into the prevertebral area somewhere at this point. Now, this was at the level of T89 and T10, where usually the splanchnic nerves, they lie in this particular area, and they try to form the celiac plexus. And the patient was in a persistent hypotension because of the continuous infusion. So when I withdrew the catheter, brought it into the paravertebral space with a re-CT scan, the patient then did not have any hypotension thereafter. Now, it's very important that the pleural punctures have been mentioned in the landmark-based techniques. And I have come across at least 2 cases where I had pleural punctures. Now, this is not a pleural puncture, but the needle is very, very dangerously close to the anterolateral part of the pleura. And one small movement or one small movement by the performer or one small movement by the patient, or the patient just coughs, it's enough for this to cause the pleural penetration. Small gauge needles like 21, 23 gauge needles, maybe it will manifest some times later, but if it's a large gauge like an 18 gauge, which I had used in this patient, you can see he immediately went in pneumothorax and had to be ICD had to be placed. So probably these kind of cases, if you're doing by landmark techniques, smaller gauge needles would be preferable. If you're using catheters, you have to do it very cautiously and probably in the operating theater where all the facilities are available. Now, this is I've done this in the past. This is my video because a similar video exists by my colleague Harshal, I think, yes. And this we used to do a lot in the past when I used to do the one lung ventilation and thoracoscopic. So in this case, the needle is being introduced by landmark technique, and when I inject in the lateral position, the surgeon is going to see how the drug spreads. So you can have a clue like how the drug spreads. Now, this is a beautiful figure where we have the axial and the sagittal both. It's like a book picture. So yeah, this is the axial, and this is the spread in the axial, and this is the spread in the in the sagittal. Now, this is an article which exists in anesthesiology way back in maybe 2008 by author named, I think his credit Kredit. So when you look at this particular, I'm now going to go into the paravertebral space. Now, once I'm in the paravertebral space, this is the loss of resistance to saline, and then I inject saline. And then after some time, the surgeon sees a swelling which occurs in the paravertebral space. He's poking with this scope with the whatever instruments he has, and you can see the spread. It's cranial and caudal, and it's exactly confined to the paravertebral space. There's nothing going into the intercostal space as yet. And when I start injecting methylene blue dye, now it can be clearly seen the spread which goes cephalad, forms a small apex-like thing. So the volume of local anesthetic which is received cranial most and the caudal most will be the least. while at the point of injection, it's going to be more. Now you don't see anything going into the into intercostal space, but when I start inserting catheter up to some mark, the catheter you can see in the paravertebral space, but then it goes laterally into the intercostal. So this is going to act like just an intercostal block. It's not going to act like a paravertebral because it's going to stay confined in the intercostal. So the length of the catheter has to be 1 to 3 centimeters. This was more than 5 centimeters inside the paravertebral space. So we started using the ultrasound thoracic paravertebral blocks after the emergence of the ultrasound. And I used to use the median oblique technique, trying to identify the internal intercostal membrane, and then going still more medially, you will try to identify the costotransverse ligament. So if you use the internal intercostal membrane as a landmark, then probably you are a bit more lateral. But if you're using the costotransverse, then you're more closer to the neuraxial space. So you need to penetrate these either or the internal intercostal membrane or the other, that is the superior costotransverse ligament. Now, cadaveric studies has seen that this definitely goes along the paravertebral space, and it also extends laterally. At the point of injection, it extends the lateral extension is more than one which is more cranial or caudal, and the density of the drug, the injection is more at the point of injection, and when you go more cranial and caudal or go more lateral, the density becomes more lesser. So this cannot be really extrapolated to the clinical, but then you'll have to identify with the sensory delineation whether the limitation of the sensory block. And when they opened up the spinal cord, they found that it had, in fact, affected the sympathetic trunk, the ramana communicants. Some of the splanchnic nerves were also affected, and this is the reason why you get a good sympathetic block. In fact, when they performed some somatosensory evoked potentials after a paravertebral block, Richardson and his colleagues, they found that it is affected for more than 48 hours. So that's the reason why the paravertebral blocks, it acts more denser than even the epidurals, the thoracic epidurals. Now, when I did some of the when I did some of the ultrasound guided thoracic paravertebral blocks, I found that many times I could go into the epidural space. So what was the problem that I was facing was I used to have one click. I thought it was the internal intercostal membrane, and I need to have another click, and that would be the superior costotransverse ligament. So I was thinking that both these structures, they overlap, but they do not. And what I was really doing was the first click was of the superior costotransverse ligament, and the second click was the that of the ligamentum flavum, which has a lateral extension. So from the epidural, from the posterior part of the spinal canal, it comes more lateral and it lies somewhere close to the intervertebral foramen. Not really in the intervertebral foramen, but closer to that. And I was traversing that particular area. And most of the times I used to find my either the catheter lying into the epidural space or the drug lying into the epidural space. So you need to be very careful when you do the thoracic paravertebral blocks in clinical scenarios. The probe placements as well as the needle placements need to be perfect, and you have to be very highly vigilant. And your pulp of the fingers have to be very sensitive to the structures that they transgress when you start inserting or advancing your needles. I had my hands on the ventilated cadavers. This we have facility we have in MGM Navi Mumbai. So if you happen to come to some of our crab workshops, you can have a hands on the paravertebral blocks. You can see the cadaver is being ventilated here, and I'm having a hands on. You can see the paravertebral space here, and the needle. I'm just trying to advance into the paravertebral space. Now, when you inject dye, now this is a formalin-based cadaver. When you inject dye, you can see the dye is spreading from the paravertebral space, of course, into the prevertebral area and then into the intercostal space. And in the next couple of images, you will find that the dye is spreading from the paravertebral into the intercostal and the prevertebral. And the next, you will find that next section, you will find that the dye is in the intervertebral foramen. It has gone anterior epidural space and into the contralateral intervertebral foramen. And you can see the thoracic nerve here as well. And it stains multiple levels. So you can see that it's going more caudal, it stains multiple levels. This staining parietal pleura is basically an artifact, and this is also an artifact, but it goes right up into the prevertebral area as well. So there's a lot of extension of the paravertebral blocks, and it is one of the most, it was rather most sought after block when we used to practice by landmark and even with ultrasound. But basically, because now the paraspinal blocks have come into practice, most of them, they have forgot what this block looks like or what this block behaves like. And I think the newer generation has to be taught by all our mentors the paravertebral blocks as well. So this is the ventral nerve, and there is a spread along the ventral nerve into the epidural space. There is a space, there is a spread even more caudal and lateral, and there is a spread which is close to the parietal pleura. In fact, we used to inject between the parietal pleura and the innermost intercostal muscle. We used to inject in between that. So we used to call it as the interpleural block. And this was, I think, we used to use in the past for cholecystectomies and many of the other surgeries, which were open surgeries, of course, not the closed surgeries. And it also migrates to the prevertebral areas. Now, when we dissected this, when we opened up the pleura here, you can see that the dye lies the dye lies in the paravertebral space. It's very dense here, so it's going to affect the thoracic nerve, which is traveling at this point, and it also affects the sympathetic chain, which would lie at this point. But there is no extension into the erectospinal plane. So it's a very confined space, which where the drug will not move from the paravertebral space into the erectospinal plane, but will move back into the epidural space. Some of the important structures, you can see the ventral rootlets. This is the dorsal rootlets forming then the dorsal root ganglion as they combine both together, and then they form the spinal trunk, which eventually forms the ventral rami, and then it forms the intercostal nerve at this point. So this is how the paravertebral block should act, in fact. Now, what are the outcomes of the thoracic paravertebral injections? We should understand this. A couple of recent studies with ultrasound. Now, what they did was, you can see that this is a comparison between the transverse and sagittal. Now, you know what is the transverse placement of the probe and what is the parasagittal placement of the probe. Now, what they found was, when they used to use this, they found that the transverse versus sagittal, the sympathetic chain was more blocked with the transverse than the sagittal. The intercostal space, it was more blocked, wider with the transverse, and the craniocaudal spread was also more with the transverse rather than the sagittal. And this is exactly the opposite thoughts that I had. Now, I used to feel, and I used to always claim that the sagittal plane would have a more spread than the transverse plane. So this is what I had thought. I had set my thoughts upon. But it is exactly the opposite that we find in the cadaveric studies. Of course, they cannot be extrapolated unless you have got studies in volunteers or in patients, when we can see on the CT scan and MRIs. But this is exactly what they found. Again, here it's very clearly depicted. The transverse more than the sagittal at the level of T4, the level of T5, and the level of T7 as well. And in the level of T3, it's more of the transverse spread. And a sympathetic chain, of course, you can see the 80 to 40%. And that would be the reason why the probably the outcomes, even the clinical outcomes would be more better with the transverse than the sagittal approach. Another similar study which had got a lot of cadavers, like 27 cadavers, and again you can see the transverse in plane, then the transverse out of plane, and the sagittal in plane. So what they had, same thing. The transverse versus sagittal, now they had sympathetic chain blocked 80% of the time. So this is the area where the sympathetic chain would lie, the prevertebral area. The prevertebral area. And this is the thoracic paravertebral space, and this is the intercostal space. Again, the intercostal space more wider. The craniocaudal spread more wider. So this is how probably the transverse plane approach it manifests, and probably it also should affect the clinical outcomes. So with the thoracic paravertebral injection, we can come to a conclusion that you have got a consistent ventral rami. It will block the sympathetic chain, and it will also block the dorsal rami. So it gives a complete blockade. It's just like a plexus block, where you have the motor sensory and the sympathetic components all together, and it is blocked with a single needle approach. Perhaps, perhaps I think today's generation may not be doing a lot of paravertebral blocks, but our mentors, I still feel, and I honestly, I would ask them to pursue with the imparting knowledge of the paravertebral blocks. It has been used extensively for breast surgeries, for the thoracic procedures, then for the chronic pain syndromes, and also for the cholecystectomies and nephrectomies, which were open in the past, but now they are doing closed procedures. Now the next would be the, now what we did was we used to hit the transverse process and then just go beyond it. Now we are just hitting the transverse process and injecting the local anesthetic. So I would urge the mentors to impart the knowledge of the thoracic paravertebral. If you have hit already, or if you have encountered the transverse process, why not go just beyond it and inject your local anesthetic? That would create either two blocks. One is the intertransverse process block, which we are going to discuss, or it can you can have the paravertebral block. So either the two would be more useful than the erectospinal plane block, which has been, I think it has been overemphasized, and a lot of things have been mentioned without any definitive conclusions of late. So again, the same, now we are targeting this particular area, that is the dorsal rami, the transverse process, and you inject large volume of local anesthetic and try to see that it goes beyond and into ventrally into the paravertebral space. So you're trying to push this local from the transverse process into the paravertebral space. Now, if you look into some of the dissections that we have done along with George Fiegel and Xavier Salablanche, you will find that it's really, really difficult for the drug to go into the paravertebral space. But still, I would also demonstrate some of the human volunteer studies where MRIs have been done, and they conclude that the drug really goes into the paravertebral space. So there is a difference of opinion now. And the cadaveric studies, again, you can see here, it does not exactly extrapolate to the clinical studies. So in 2015 and 16, before the emergence of the erectospinal plane block by Forero, I was attempting in 130 kgs patient who had got a good amount of fat posteriorly, and then I had a loss of resistance, and I injected local anesthetic and I inserted a catheter. On day 1, she had 40% pain relief with 8 ml per hour of 0.2% group awaken, and I thought that I was in the paravertebral space, but somehow I felt that at the back of the mind, I felt that somewhere I'm going wrong. If I'm in the paravertebral space, why she should have only 40% pain relief? So I did a contrast study, and to my surprise, the contrast was lying below the trapezius. Though it was not lying in the erectospinal plane, it was lying below the trapezius, and even that the patient had pain relief, probably because of the continuous irrigation of local anesthetic. Drug might be seeping from this area into the erectospinal plane. Probably yes. I'm not sure about it. So this block was mentioned by Forero in chronic pain, and we all know that where the drug is injected, just at the level of the transverse process and just behind the transverse process. So beyond the transverse process, ventrally, well, is the paravertebral space, and behind the transverse process, but in front of the erectospinae would be the erectospinal plane. So scientifically or academically, we mention as deep to erectospinae and superficial to transverse process. That is the erectospinal plane. Now, what is claimed here is that when they did the cadaveric study, they found the methylene blue dye going dorsal all across the dorsal of the transverse process and deep to erectospinal plane. So this they mentioned as erectospinal plane. Patient had pain relief. They found that the dye was all superficial to the transverse process. But what they found was there was something that might have led the drug into the ventral area, and this is the costotransverse foramen. So this again became a very popular target area, the costotransverse foramen. So if you look into some of the slides, the cadaveric slides, you'll see that this is a fresh cadaveric specimen. And in prone position, we have reflected the entire area of the back bilaterally. This is the spinous process, and this is the posterior part of the thoracolumbar fascia. Now we look into the next slide where we lift the trapezius from the back to expose the rhomboids, and this is probably the serratus posterior, and we have got a serratus anterior and the serratus posterior. And these, what you see, are the uh, erectospinal muscles. So which extends from the midline. You got the medial one, which is thoracospinalis, the longissimus, and the iliacostalis. Now, when you start dissecting further, you will find that these muscles, that is the spinalis, thoracic spinalis, the longissimus, and the iliacostalis, they become more of a tendons here. And the bulk of the muscle, it lies in the lumbar area. So the multifidus, what we call as. So they reflect as these three muscles, and then they become more of tendons here rather than the muscles. Now, what we always mention in our technique is deep to the erector spinous sheath. Now, deep to the erector spinous sheath is where the sheath is hyperechoic. Now, one more thing I'm still unsure is whether we are seeing these tendons as the sheath, as a hyperechoic sheath. Because if you try to move from one point to the other point, sometimes you miss that particular hyperechoic area, and you can be in between these two hyperechoic area where you can see the muscle deep to the erector spinae. There is also muscle deep to erector spine. Now, this is just a schematic diagram, just blown up to show the multifidus and then the thoracospinalis, the longissimus, and the iliacostalis, which forms more of a tendons here. The bulk of the muscle is lost, and in between you will find the other muscles. These are the short muscles of the back. Now, what you do is routinely you place the probe. Now, this is a parasagittal. You can also place it transverse. The needle is either from caudal to cranial or from cranial to caudal, it depends. And you're trying to place your needle beneath this, what we mention as a sheath. Now, this sheath, whether it's a part of the tendon or which is above, or it can be below the tendon as well. So if it is above the tendon, it means that you are injecting a local inside the erector spinae muscle. If it is below, it means you're injecting it between the erector spinae sheath and the transverse process. So this you can see the needle tip. I'm unsure whether it is anterior erector sheath or these are the erector tendons, and you're placing it in the sheath of the erector tendons. Now, once you remove all the tendons and you reflect the bulk of the erector spinae muscles along with tendons, what you find is this is the spinous process. These are going lateral to the spinous process. These are the short muscles. Now, these have been called by several names like rotatoris, levadoris, costarum, interspinalis, or intertransversi. These are some of the muscles of the back. More important is these are the transverse process. So these are the three transverse process. Connected between the transverse process is the intertransverse ligament. You can see the intertransverse ligament. So basically, when you are placing your needle tip is being placed either at the transverse process or in between the two transverse process at the intertransverse ligament. And once you start injecting it, it means that the drug is not necessarily going along this longitudinal path. It goes retrolaminar. This is the laminar area, and it goes in the endocostal path. So this is the more lateral path. And you can see the extent of the tissues here. You can see the tendons, you can see the muscles, you can see the bone. So it's a huge column, an entire column of the bone along with the muscles and the tendons and the ligaments. So a lot of things which come in play here, and this is what I call as an osseous tendinous muscular network, which will form an anatomical barrier once you start injecting local. It's hardly that you will find that the drug can go beyond this area. Unless and until you'll find that this particular, what we had discussed, that is the costotransverse foramen. Now, through the costotransverse foramen will emerge the dorsal rami along with the vessels, and this may be the path ventrally towards the paravertebral space. So probably, if you are trying to target this particular area, that is the costotransverse foramen, then the drug might reach the paravertebral space. And a lot has been now discussed about this particular block where the drug can spread. The standard volume is around 30 ml. 20 ml would be more or less. 30 ml would be more than optimal. 40 ml and 50 ml would be more than what is required. So 30 ml is what is said to be appropriate. And you can see that if you inject 30 ml, it doesn't mean that all the 30 ml is going to diffuse into this particular area. It is only the volume, the speed of injection, the gravity, all which accounts, which helps in spreading the drug from the dorsal to the ventral. So probably in the prone patient, it would be more effective ventral spread rather than in the sitting position. So that's the costotransverse foramen, which has been depicted here. This is from some other article. Now, where your needle is positioned, the needle is positioned like this is the spinous process, this is the lamina, this is the transverse process, this is the costotransverse junction, this is the paravertebral space. That is the rib. This is the erector spinae muscle. That's the erector spinae plane, which is deep to the erector spinae muscle and superficial to the transverse process. Now, this is the axial section, what we are looking at. That's the retrolaminar area, which we were looking at in the dissected specimen. This is a cross section. And that's the paravertebral space. So somewhere between the retrolaminar area and the paravertebral space and the erector spinae plane and the paravertebral space, this space would be the space which we now call it as the intertransverse space. I call it as the interligamentary space or the costotransverse space, which is to call in the past. There are so many terminologies, but nowadays the ITP is supposed to be the term which is used in this case. That is the intervertebral foramen. This is the epidural space, and that's the intrathecal space. That's the spinal cord. Now, what we did was we tried to dissect the entire erector spinae plane, and we found just the dorsal rami. If you dissect this paravertebral space, we could see the ventral rami. You could see the dorsal rami here. And what we lifted here was a part of the combined parietal pleura and endothoracic fascia, which would form a barrier as it moves more cephaloid. It forms a barrier. So you have the transverse process, then you have the intertransverse ligament between the transverse process and the other transverse process below. Then you have the erectospinal plane. You have the entire parietal pleura with the endothoracic fascia, and this would be the paravertebral space, which we have discussed earlier. And this is the ventral rami, which would then travel from the intervertebral foramen through the paravertebral space, will not go through the erectospinal plane or even the intertransverse space, and then go more lateral and caudal, and then anterior. And the dorsal rami is the one which will pass through the erectospinal plane and the intertransverse plane. So if you're looking at these particular blocks, you're just going to block the dorsal rami in the erectospinal plane. Now you have seen the axial. Now you have to see the sagittal. Now you have to be very, very attentive here, because this, even when we took a section, even we both, myself and Zero, were confused what these structures are. But when they slowly try to decipher what the structures are, now this is the lateral part. This is the lateral part. That is the medial part. So this is the pleura, and these are the mediastinal structures. This is the aorta. Now look at this, is all the transverse process and the ribs. So this is the so I think I have labeled it the other way around. So this has to be the transverse process. These are the ribs. So take into granted that this is the transverse process and these are the rib. This is the transverse process and these are the ribs. Now, if you find that there are some structures here, which is communicating between these two, communicating between these two, and also communicating between these two, that is between the transverse process. So between if it is between the transverse process, it's the ribs, and if it is between the costotransverse, it's the costotransverse ligament. So when you have these structures in place, you'll find that this is the erectospinal plane, which is deep to the erectospinal muscle, and this is the intertransverse space, which is interligamentary space, which is between the intertransverse space or the interligamentary space, which is between the two ligaments. Now, two ligaments is the intertransverse ligament and the costotransverse ligament, and then you have the paravertebral space, which is beyond the costotransverse ligament. So this is how it looks like. This is the general outlay of whatever we find during the sagittal section. So the erectospinal plane is more superficial, the paravertebral space is more deep, and the interligamentary space or the intertransverse space is in between the two. Now, when you insert your needle deep to the erectospinal muscle, it lies deep to the erectospinal muscle. It is the erectospinal plane. So this all is the erectospinal plane. And we try to inject a local anesthetic, and we try to overcome a couple of barriers to see that the drug then percolates deep into the and ventral into the paravertebral space. That is what we are supposed to anticipate. Now, there are a lot of studies, study 1, 2, and 3 by various authors, where they have injected dye. They found that it all affects the dorsal area. It all affects the dorsal area, and none going and affecting the ventral ramus. None going into the intervertebral foramen, and of course, none going into the paravertebral space and the epidural space. Again, there would be hardly 1 or 2 levels where the ventral rami could be affected, while the others have seen that 20 ml of dye has never affected any of the ventral rami, hardly any of the ventral rami, but more of a dorsal spread. Another very important study by these authors, they found that it's very unpredictable. With erectospinal plane block, again, 20 ml given at the level of 2 levels. One is at T2 and other is T8. They found that the dye spread is absolutely unpredictable and more of craniocaudal spread than of the ventral spread. It all depends upon what type of cadavers you use. It may be formalin based, soft, embalmed, thiel based, or fresh frozen. Now, when I did a formalin based study and I injected in the paravertebral space, you can see the dense spread here going into the epidural space and then coming retrograde into the erectospinal plane. And when I injected into the erectospinal plane, it went into the it went into the paravertebral space and then into the epidural space. So even if you're giving it the paravertebral in the formalin based or the erectospinal plane, it does go ventrally and it does come dorsally, and both into the epidural space and intrathecal space. But remember, this is a formalin based cadaver. When recently we published with 20 ml latex and thiel embalm, we found that it's only the dorsal rami spread. It's only the dorsal spread. There is no ventral spread, no paravertebral, no epidural intrathecal spread, of course, but more of the dorsal spread, affecting probably only the intercostal nerves. And there was hardly any drug, very minuscule amount of drug going into the paravertebral space, which would be this. The green dye, only hardly any dye, just reaching the paravertebral space, while the blue reaching the paravertebral with a very small volume of the injected. Now, if you see that whether this amount of dye, now suppose this is a local anesthetic drug, will it produce a meaningful analgesia? That is what we want. While this one and this spread, how important it is while producing a meaningful analgesia in the post-operative period? That's the big question here. So with the cadaveric models, we found that uh, uh, these studies by Ferrero, Adhikari, Vidal, and Young, they found that it's more of the dorsal rami, less of ventral, and these authors they found that it's mixed, but they had given all had given a single short erectospinal plane block and had given multiple injections. While our study we found that in the cadaveric, the posterior there is some anterior extension. It is likely mixed, but the anterior extension is may not be extrapolated clinically to a meaningful analgesia. And in a recent article along with Xavier Sala, we found that it's totally a dorsal rami block. It doesn't spread ventrally at all. So that is what we concluded in our study recently, which was published in Wrap-Up. So the erectospinal plane block is a consistent dorsal rami block, while it's an inconsistent ventral rami block, as against the paravertebral, which is exactly opposite, which is a consistent both ventral and dorsal rami block. Plus, an additional advantage is a sympathetic block as well. However, when we did cadaveric studies in 5 patients, we injected with the catheter, of course. And at the erectospinal plane, you can see there is a spread in the retrolaminar. There is a spread through the costotransverse foramen into the intervertebral foramen, going into the epidural space posteriorly, and then contralateral intervertebral foramen. That was the spread with 20 ml, but this was at the level of T5. Now, remember that at T5, you have got a sort of deficient costotransverse ligament. And this is by embryology, where anatomically the costotransverse ligament at T4 and T5 are sometimes deficient. And this is an advantage where you place the needles at the erectospinal plane, where you can have the drug diffusing into the paravertebral and epidural space. That is a probability. Another study, a recent one, this is in British Journal, and you can go through it. 30 ml they injected. They found the paravertebral space 96.5% of the times, and intercostal space 94.2% times. The neural foramina almost 77, and epidural space 16%. So that was the spread with around 30 ml of contrast which was injected. And what they found was that though the dorsal rami, there was a craniocaudal spread, they also found that the drug going into the intervertebral foramen and into the epidural space and sometimes in the contralateral space. So they did find with MRI studies. So the recent MRI studies have concluded that there is a drug uh, migrating from the dorsal erectospinal plane to the ventral paravertebral space. Now, so we come to a conclusion here that the cadaveric studies somehow they have mixed results with the dorsal and ventral affected, while some cadaveric studies they mention only the dorsal rami. But recent MRI studies have found that the drug really going into the paravertebral and epidural space. There's one more article by Sorensen in Rapam, but I could not get hold of it. This is the latest article which has appeared in the journal. So what we conclude from this particular two blocks is that maybe we do not need to enter the thoracic paravertebral space. You just need to reach the right connective tissue gateway. Now, what does it mean? Now, it means that when you are near the erectospinal plane, probably you are lifting several of these fascias and your needle tip might be beyond even the erectospinal plane. And you may not reaching even the paravertebral space, but your needle might be somewhere in between. And that exactly is the intertransverse space. So this was the birth of paraspinal blocks, where you have got a lot of these blocks: midpoint transverse process to pleura, multiple injection costotransverse block, the costotransverse foramen block itself, and then the subtransverse process into ligamentory plane block. So these are some of the blocks that have been described in literature. We're not going to take each of these blocks. We're just going to look into journal in general. Now, why so many blocks? Now, this was exactly the question which was raised by Serkan Tugler, my friend from Turkey. But before that, we'll have a look at the anatomical structures which have been very nicely depicted here. You can see the intertransverse ligament between the two transverse processes. They're going oblique. The superior costotransverse ligament from the rib to the transverse process, again oblique, and you can see that they're almost parallel. So if you keep your probe here along this median oblique, this exactly will overlap each other. And your needle will then transgress through the intertransverse ligament and the costotransverse ligament into the epidural space. What they have held up here is this is the intertransverse ligament, which they have pulled up. Now you can see there are two sleeves of the intertransverse ligament. So probably when you're injecting local, your needle might pass through this and then go beyond this into this space, which is behind the costotransverse ligament, which is called the retrocostotransverse space nowadays. And then this is the ventral nerve which has been held, and the superior costotransverse ligament beyond the superior costotransverse ligament, and this is the paravertebral space. One important thing what this article mentions is that instead of using a 23 gauge needle, spinal needle, if you're using a 21 gauge needle, there is a 6% improvement in diffusion of local anesthetic from the intertransverse space to the paravertebral space. And they have found that the fluid can diffuse through the costotransverse foramen. This is a very important article, and I think each one of you should read this article, the anatomic classification and clinical application of thoracic paraspinal space. There is a plethora of variables here. You can see that this is the site for the retrolaminar block. This is the spinous process. This is the lamina coming right up to the transverse process. This will be the erectospinal plane block. Going beyond this would be the costotransverse junction. Entering here would be the paravertebral space. This is the costovertebral junction. So between the erectospinal plane and the paravertebral space, somewhere at this point would be the intertransverse plane. Now this is the axial section. If you come to the sagittal section, you can nicely see here two transverse process connected with the intertransverse ligament, and then this would be the superior costotransverse ligament, beyond which would be the paravertebral space, which will have the motor and the sensory nerves along with sympathetic. So you have got the ESP, you have got the ITP, and you have got the paravertebral space. Each has got anatomical landmarks. But then this is a blown up figure where you can see the between the rib and the transverse process, you can see the costotransverse space, and the retro superior costotransverse ligament space is just beyond the behind the costotransverse ligament. Now this is a micro CT which has been blown up. Now this is a very small space. If you look into the dissections, if you go to the dissection hall, sometimes you can get hold of some of the cadavers and try to see how the dissection specimens look like. These are very small spaces, which would not require much of needling. And this is the reason why Tugler came out with the question, why too many injection points? You can see the needle's tip being positioned somewhere at these points, and you have got a block in your name. So probably this small space does not require so many needle injections. So what we did was we came out with an article on anatomic barriers to paraspinal blocks, where we mentioned that you have got just three spaces. One is the erectospinal plane, where you have got the needle tip position. That is the two transverse process and the intertransverse ligament, and just deep to the erectospinae and superficial to the intertransverse ligament. The next needle position is beyond the intertransverse ligament, but superior to the superior costotransverse ligament. That is in the, nowadays we call it the intertransverse space. And the third, of course, will be in the paravertebral space. So just three needle positions, just three spaces, and nothing else. And we found that there are two big anatomic barriers for the for these spaces. The one is the intertransverse ligament itself, and the second is the superior costotransverse ligament. These are the two most important anatomic barriers. This is a space which should be again an additional barrier for the erectospinal plane. So you can see now the needle in the beyond the erectospinae in the intertransverse space. So between the transverse process and the rib, the superior costotransverse ligament, between the two transverse, the intertransverse ligament, and you can see this is the costotransverse space, which just has got the dorsal rami. And your drug has to spread beyond the costotransverse ligament into the paravertebral space. Somewhere here would be the costotransverse foramen. And if your needle is directed towards the costotransverse foramen, probably your drug might be into the paravertebral space. So we did a study where again what we did was we tried to inject into the paravertebral space first. We saw that there was, and we just took sections. We did not dissect, because sections will not destroy the drug or migration. It will be very static. While with dissection with your fingers, the drug migrates and you can have a false impressions. So you can see the drug in the intercostal space going around the nerve root. This is the paravertebral space. Behind that is the costotransverse ligament. Behind this will be the intertransverse ligament, intertransverse space. Behind that will be the intertransverse ligament. So we are going from the front to the back. If you go from the back to the front or from the dorsal to the ventral, you will find that this is the erectospinae muscle. That is the erectospinal plane. This is the transverse process. So in front, and you have the costotransverse ligament here, and the needle penetrates the costotransverse ligament and is in the paravertebral space. But you can see that some of the drug, it does seep into the costotransverse space or the interligamentary space or the intertransverse space. In the next figure, you'll see that we have gone beyond, we have come behind the costotransverse ligament and we try to inject. It highlights the entire costotransverse ligament, but the drug seeps through the nerve roots. So these are the ventral nerve roots. It seeps through the ventral nerve roots and then into the intercostal space. But you can see how dense it is here and how mildly stained are the nerves here. So clinically, the intensity might be less. Again, you cannot extrapolate cadaveric studies to clinical studies. But the most important point is you can place the needle between the intertransverse ligament and the costotransverse ligament. The drug can spread from cranial to caudal, drug can spread from dorsal to ventral, and you can achieve what the paravertebral block can achieve by positioning the needle behind the costotransverse ligament. So intertransverse process block, whether it gives a consistent dorsal rami block or a consistent ventral rami block, we need to do a lot of clinical studies. There are a lot of clinical studies that are coming into picture. There is a narrative review on intertransverse process block recently, which has been published by some of the Chinese authors. I don't remember the journal, but I think it's Journal of Anesthesia. and you can go through it if you can get hold of it. So finally, we have the needle going through the intertransverse into the uh, costotransverse space, and then through the costotransverse ligament. What we have lifted with the forceps is the ventral nerve root. And these are the three planes: the erectospinal plane, the costotransverse plane, and the paravertebral space. These are the only three planes that you have. So this is just the picture of the erectospinae, and you can see the erectospinae plane. This is the transverse process and the intertransverse ligament. The needle going to the intertransverse ligament in the costotransverse area. This is the superior costotransverse ligament. The needle going through the costotransverse ligament, ultimately into the paravertebral space. So these are the paraspinal blocks that we have to think of, that we come across. Of course, in the exams, you might have to learn few of those or remember those blocks which have been mentioned earlier. So all those blocks which have been mentioned earlier, the mid to transverse, the costotransverse foramen, and the still block, all these blocks, they come into the group, or they're grouped into now the intertransverse plane blocks. So I think this is it. Dr. Sangha, Dr. Hetal, he must have left, and Dr. Abhishek. Thank you very much. The other part, that is the PEG block and the SAP block, that is also still, it remains. So I will combine it with the infraclavicular and the costoclavicular and the axillary blocks.
Right, sir. We can take that class next month.
Yeah.
Let's schedule a date. Any questions from fellows, faculties?
Or they can also comment. If they don't want to question, they can comment also, not a problem.
No, I just have a query. How many of them are actually practicing landmark guided paravertebral block and all? Because yes, as you have rightly said, sir, we have started learning from that point, and every one of them nowadays have a access to USG. So I'm just curious, how many of them are learning the landmark technique of needling? If anybody can answer from the fellows, and what is their experience with it?
Good evening, ma'am. I'm Dr. Divya. And ma'am, I have been practicing paravertebral block for breast surgeries and thoracoscopic surgeries, and through landmark only, because I find it little difficult to see it with ultrasound. So, and managing both the probe and then needling, I find it very difficult. So mostly I go through landmark technique. Yeah.
Right, ma'am. So my question will not now go to the faculties here, those who are especially having fellows, how does it go in your setup? So are we teaching first landmark guided to the fellows or directly USG guided? If any faculty is interested.
I think Neeta is here. Neeta can answer this.
Good evening, sir. Excellent. No words to express in the depth in which you have covered the topic. With regards to teaching and with regards to practice, I too started with the landmark guided, but having the ultrasound in our armamentarium, I think it is advisable to do an assisted. I completely agree that doing a live block with multiple hands and not holding the probe yourself, but taking assistance could be challenging. But considering we have fellows, every block starts with landmark, and I think we should progress to an ultrasound assisted at least to know that we are in the right place. There are many times we give a paravertebral and we are hoping it's in the right place. So there are instances when it converts into an intercostal block if it's too lateral. So I believe the way forward is landmark with assistance, so that the fellows also are pretty much convinced as to in which plane the drug travels. And there is more surety, is what I believe. And I have been practicing for the last 2-3 years at least. Thank you.
Thank you, ma'am.
Thank you, Nita, for mentioning this in particular, that landmark guided blocks have to be learned by each one of those fellows. It's the mentor's duty that all faculties based in all hospitals throughout who have got AOR fellowship, as well as the AFRA, which is upcoming. And these landmark based techniques have to be demonstrated to all AORA fellows. So we have started this now in our institute as well, right from the beginning. To start with simple blocks like the interscalene, supraclavicular, infraclavicular, axillary. This can be demonstrated, femoral, sciatic, popliteal. Later on, maybe the other landmark-based techniques can be mentioned. There are a few questions. Can we take those?
Yes, sir. So Dr. Bhuna has asked, good evening, sir. Cadaveric studies suggest that ESP block mainly spreads to dorsal rami and only inconsistently to ventral rami. But clinically, we still use ESP for breast surgeries for post-op analgesia. Could you explain how we are getting effective analgesia in that case?
Yeah, so if you have been practicing this and if you're getting good analgesia, it means that there are two things. One is that it's been producing what is called as a differential analgesia with particular affection of the C fibers and not of the A delta fibers, probably. That is one. And second is it might be producing its effect through what we call it as an intravenous absorption. So these are the two possible. These are the two possible mechanisms by which the block would be working. The third thing is that if you have been giving at the level of T4, T5, as I said, the costotransverse ligament, they are deficient, and there would be passage of the drug from the dorsal to the ventral. It all depends upon the amount of local anesthetic which has come onto the ventral aspect, and that would determine the quality of block. So probably it could be those few things which would matter when you do the erectospinal plane block. Third thing, another thing that would be the fourth. You may not be in the erectospinal plane at all. Your needle must have transgressed the anterior erector sheath as well and into the intertransverse space and must be causing an intertransverse plane block. So that could be an inadvertent paravertebral in that case. So there are so many things which would explain why your block could be effective. Having said that, you should go through one article in RAPM where it mentions that the erectospinal plane block dash it may be statistically significant but clinically meaningless. Especially for breast surgeries. So I think you should go through the article which explains in detail about the problems of the erectospinal plane block for especially for the breast surgeries. I agree that if you have been giving for spine surgeries, I agree for that. If you're giving it for chronic pain of spine, I can agree for that. To some extent, on the lateral aspect for thoracotomies, I can still agree. Lesser than the previous, like for the spine. And for the breast, I really don't agree on this. So that would be my take on it. If you go through some of the systematic reviews and meta-analysis, the pectoral blocks are equivalent to thoracic paravertebral blocks, but the erectospinal plane blocks are never equivalent to the paravertebral blocks, particularly for breast surgeries.
Right, sir. Dr.
Yes.
Manjula ma'am is asking.
Yes, this is again the problem that I have created for her and for yes. Full journal name in your references. Yes. So I can now incorporate the next time. I will give you the QR code, which Divesh usually gives all the QR codes. He
Yes.
does a good job in that. So I will give the name of the entire article or the QR code. I will do that, ma'am.
Thank you, sir.
So Dr. Hema Kumari is asking, good evening, sir. How is the caudal spread of paravertebral block, sir? psoas limits the drug spread.
Yeah, so that's a wonderful limitation of what she has mentioned, the caudal spread. So the paravertebral spread, it really does not until and unless it should enter through the endothoracic facial connections into the transversalis fascia plane. So probably we are looking now into these facial communications. We have a study with Dr. Manjula ma'am and Dr. Yogita in Bangalore. So probably we'll come out with more details when we do this. We're trying to look at the facial communications throughout the body, throughout in the cadavers. So many a times the if you do a lumbar, if you do a which is that block? the chordatus lumborum block, sorry, the posterior chordatus lumborum block. When you do that block, it ascends into the paravertebral area. How does it do? Or if you do an anterior chordatus lumborum, it enters into the lower paravertebral. It is basically through the arcuate ligaments. And these arcuate ligaments, they provide a deficiency through which the drug extends from the caudal to the cranial. So if it is extending from the to this particular area, definitely if you are doing the blocks in the lower paravertebral area, it can extend into these particular areas. So that's what we are trying to look at, whether these arcuate ligaments, they form the barriers or they do not form a barrier. Now, if you consider the superior costotransverse ligament as a barrier in the paravertebral space, what I was thinking and I was trying to understand myself was whether these arcuate ligaments are the remnants of the superior costotransverse ligament in the lower thoracic or the upper lumbar areas. And they have been deficient and creating a gap or a communication between the thoracic and the abdominal areas. So that is what we are looking at. Lumbar plexus block, if you inject, the drug never ascends into the paravertebral. It can go into the epidural space, but lumbar paravertebral cannot become a thoracic paravertebral. I have not heard of it. I have not seen it. I have not visualized it. I have not read it in cadavers, nor clinical, nor contrast studies. Did you get it?
Thank you, sir.
Yes, sir.
I think we are done with the questions.
Yes, sir. Any more questions?